I'm not based in Canada. I'm not very familiar with the Canadian system. I know a number of people in Canada, but this comes up all over the place. And I think the most important thing is that if you can find a physician who is empathetic, is willing to listen and is curious and cares about helping you, that's almost more important than what type of specialist they are. You know, obviously, if ideally they know a lot about these conditions, but people don't always find that perfect match of, accessible, covered by your insurance. You can get an appointment in a reasonable period of time. It's really hard to find that. So sometimes you have to work with your PCP, for example. Maybe your PCP is somebody who is actually curious about these conditions and is willing to have more of a dialogue with you. And if you can, say to them, if I come back for another appointment in a couple of weeks, can we dive a little bit deeper into this? Because we know that ideally, everyone could get to see a group of specialists under one roof, multidisciplinary type thing. That would be amazing. And that's really what needs to happen at some point in the future, but we're a long ways from that. So in the meantime, whether it is your pediatrician, your cardiologist, your internal medicine doctor, your family practice doctor, if you can find somebody, one person who really cares, and it could be your physical therapist, somebody who really cares and wants to help you, and because they'll help you get linked up with other specialists and other providers that you need. We have a waiting list right now that kind of continues to grow, unfortunately, because I see patients in person in Colorado and in Wisconsin. And you have to be seen in person first in order to be established as a patient. If you get established as a patient, I can make diagnoses, I can order labs, I can order imaging, I can, order whatever kind of testing that we need, and, prescriptions and all of that, which obviously that's great, but that's very time consuming. Intakes, the longest intake is 3.5 hours, and that's the face-to-face time. So then there's the time that I spend before that reviewing things, and then the time that I spend after that writing the notes. So it's an expensive process. I do also offer coaching, and that is much more feasible. You don't have to buy an airline ticket to fly someplace. You can, because it's all virtual, you can do, as many sessions as you want. They're still not cheap, but at least it's more affordable for most people. And what I do in those coaching sessions is I give people very detailed notes on, this is how I handle these cases, but I write it in a more general way. So rather than writing you an actual prescription for a medication, I will write, for example, low-dose naltrexone. Low-dose naltrexone is very beneficial in people with persistent pain, hypermobility, et cetera. And then I give a list of references, and then I'll even say, like, this is how I prescribe it. Obviously, you then have to find someone willing to prescribe it, but I kind of consider myself like the detective for your other doctors. And so you can take that note then to them, and it's kind of all laid out for them from a physician who specializes in this. And so that way, a lot of people have really been able to get much better care. And I know a lot of people who have taken those notes to their other doctors and have gotten diagnosed with EDS, have gotten more lab tests, gotten medications prescribed, et cetera. The short answer is no to the last part. Absolutely should not be the gatekeeper to the diagnosis. It is very problematic that the diagnostic criteria, in my opinion, that the diagnostic criteria for hypermobile EDS starts with the Beighton score, because then if you have historical joint hypermobility, and like in my case, I was diagnosed with EDS in 2012 or 2011, something like that. But I can't really do any of the maneuvers anymore, at least not safely. I think I have one elbow that still hyperextends, but that's pretty much it. And I definitely had a 9 out of 9 before. And it is, to me, the 5-point questionnaire is the most valuable tool. Were you able to do the, thumb touching the wrist, and were you able to do party tricks as a kid and things like that? Because we know that people with age, they lose some of their joint hypermobility, but that often tends to be the time when they start to run into more problems. So I think that the Beighton score it would be like a great, quick and dirty screening thing that I would love to see pediatricians doing it in their offices. And then, at certain ages kind of know, like, okay, well, this is normal for a kid to have a relatively high Beighton score, but then they could be more aware if this kid starts to run into problems with, more sprains and strains and subluxations or dislocations, whatever, then at least they would have that baseline. Injuries, surgeries, those all affect our joint range of motion. So it's really, it is really challenging with the Beighton score. For me, I work a lot with dancers, and the lower limb assessment score is a really great scoring tool for that population because they tend to get more injured in their lower extremities. There's a couple of different spider type tools. So one of them, Dr. Claudia Miller, she is a internist who specializes in environmental toxicants, and this the concept is, or she's written tons of papers on this and has heavily researched it, and it's called TILT, toxicant-induced loss of tolerance. So this tool is available online. It's called the Keesi, QEESI. You can go to the website and you can fill it out online, and you can get a score to see whether or not potentially exposure to toxicants has reduced your ability of your mast cells to tolerate, exposure to other things. So because we now think that potentially this is some of the ways that people get mast cell activation via exposure to these toxicants. And then if you have mast cell activation causing degranulation of the mast cells at a more lower level, lower stimulation, now you have all of these, lovely proteases and things that degrade connective tissue. And this is definitely a way that hypermobile EDS can develop. So it's hard to know. We don't know the mechanism yet connecting, POTS, EDS, and MCAS. We really don't know what the mechanism is, but there's at least some research and some papers on, that maybe some cases of hypermobile EDS may be caused by mast cell activation syndrome. There's a great paper by Dr. Larry Afrin about that. So the spider tool that I can't remember which one I showed, but then the spider tool that there's a group, I believe it's part of EDS UK, that they're working on that. I don't think that's publicly available yet. So I just interviewed Dr. Dacre Knight yesterday, who is the founder of the EDS clinic at Mayo Clinic. And we discussed genetic testing quite a bit. And they found in the beginning, 70% had no mutation at all. And then I think it was only 2% that actually had any kind of pathogenic type mutation. And I believe what he said was that the numbers were even more considerable now, that like even as a lower percentage where they're finding pathogenic mutations, they're not testing everyone who has hypermobility. We don't know any hypermobility genes. So really the time that you for sure want to do genetic testing is if you suspect vascular EDS, because that has a very different treatment path. So it's very, very important to test if you suspect vascular EDS. The approach that I take in my practice is, I do the intake of reviewing all the forms and whatever, records and things. And then I do a physical exam. And on the physical exam, I'm looking for, is this mildly hyperextensible skin or severely hyperextensible skin? Are these scars slightly widened? Or are they severely widened? I have a patient who was diagnosed with hypermobile EDS, and I'm like, this looks like classical. This really looks like classical. So I did do genetic testing on her. I do genetic testing. I don't know what percentage of my patients that I do genetic testing on, but it's not an insignificant percentage. But if the person really seems to fit the hypermobile EDS type classification, then, the genetic testing is virtually always going to be negative. And the problem is those things cost money, they take time. And then if you come up with, kind of a non-helpful result, there's a lot of reason to kind of focus your efforts elsewhere, I guess. It's a moving target. So, whether you have EDS or not, or EDS or HSD, this is true for all of us. So as we age, we should be evaluating our exercise regime and all of the different things that we're doing regarding movement, and really making sure that it's a good fit for where we are at that point in time. Somebody in their 60s should not be doing the same exercises that they did in their 20s. It's like Michael Phelps, when he went back to do the Olympics another time. He said, I had to train smarter, not harder. So you have to be really, really thoughtful in what kind of exercise that you do. And it can be harder to build muscle mass as we age. It's sarcopenia is loss of muscle mass, which is very, very commonly associated with aging. And it can be really, really challenging, especially if you have some joints that are arthritic. And, I definitely have faced this problem. It's really hard, but you need to look at like your nutrition and see, is there anything you can do nutritionally that can help with that? That's where I love working with my physical therapists and getting really specific guidance from them. They can look at me and how I'm moving and really help me do the correct exercises for my body at that point in time. One of the things that I find definitely really challenging is I work with a lot of athletes who, and I get it because I was super athletic before I fell off this mountain bike in 2009. And that kind of led to this terrible downward spiral for me. I was in the best shape of my life in 2009. And then in July, I fell off this bike, and then it just ended up in a terrible, terrible place mentally and physically. And, it's hard. I had to go through a lot of grieving that, I'm never going to be able to do these things. I ended up selling my skis, selling my bike. It's hard. But you got to work with the body that you have at this point in time and really, optimize things given the circumstances. Yeah, fatigue is a tough one. So I would say that after pain, fatigue is the second most common thing that I hear about from people. And it is really, really challenging. It depends on a number of factors. So, fatigue can be related to poor sleep. Maybe the person has sleep apnea that's undiagnosed, and so that has been undiagnosed and untreated. Maybe they're not getting good quality sleep. Maybe they're waking up because they're in pain. So then working on their sleep will be a first thing that we really focus on. Maybe it's a nutritional thing. Maybe we need to really make sure that they're, getting the right nutrients and spreading those out throughout the day. Definitely could be related to hydration. There's a lot of different things that can cause fatigue. And so it's really a matter of determining what we think is contributing to the fatigue the most. And then, sometimes it's a little bit of trial and error and working through some different things to see if we can get the person, having more energy.